Next up, we have Dr. Michele Sexton from the USA talking to us about opiate tapering. The topic of her presentation is Cannabis as a Substitute for Prescribed Pain Medications, Theory and Clinical Practice. Dr. Michele Sexton began her career as a home birth midwife and herbalist. She has a doctorate in naturopathic medicine and completed a postdoctoral fellowship at the University of Washington in 2011. Her NIH-funded pre-doctoral and postdoctoral research was on the topic of cannabinoids and their roles in neuroinflammation and neurodegradation. The postdoctoral project investigated cannabis use and impact on endocannabinoidal and inflammatory markers in patients with multiple sclerosis. Dr. Sexton is the Medical Research Director at the Centre of the Study of Cannabis and Social Policy and serves as an editor and technical advisor for the American Herbal Pharmacopoeia Cannabis Monograph. Some of these words are amazing, aren't they? Her clinical practice, research and teaching focus is on the medical use of cannabis across a range of conditions and age groups. So please, can I ask you to give a warm welcome from the USA, Dr. Michele Sexton.
Thank you so much, Lucy, for inviting me. This is my first trip to Australia, and so far I'm really enjoying all of the fellowship and friendliness. So just to tell you a bit more about myself, I did do a doctorate in naturopathic medicine. That may be a bit different from naturopathic medicine in Australia. Our medical training is identical to conventional medical school training until it comes to our treatment modalities. And we are trained in pharmacology, and often we have pretty good prescriptive authority in different states. We're considered primary care providers, but we really focus on prevention and alternative or traditional healing modalities as well. So I was interested in research. I was doing, my undergraduate was actually in horticulture, and I never really thought or planned that I would one day study cannabis at all, but I was studying a protein that was upregulated in neuroinflammation in my undergraduate. And when I got to graduate school in Seattle, I met Nephi Stella at the University of Washington and ended up working as a pre-doctoral and postdoctoral fellow there. So got very steeped in the pharmacology of cannabinoids for 6 years. And when I finished that, I went back into my clinical practice, and it became sort of a specialty that grew out of that experience of mine. And in the early days, I was seeing quite a few pain patients. This was in Washington in 2010. And then soon after that was the phenomena occurring with the children with pediatric epilepsy. And so had quite a good clinical group of pediatric patients that were accessing a cannabis varietal in Washington state. And then I moved to California, and interestingly, am seeing mostly pain patients now. So I'm going to tell you a bit more about that. These are some organizations that I'm affiliated with related to cannabis, and I don't have anything financial to disclose. This is a picture of my home beach in San Diego. This is Pacific Beach. And so during my slide presentation, it's divided up into sort of different sections of the talk, and every time you see a picture, you'll know that we're coming to a new section. So the foundation of what we're going to talk about today is a public health imperative that we need new approaches to pain. And I think it's probably universally felt, but particularly by the countries, which include Australia and the US and most of Europe, that have access to opiate medications. The costs of this inadequate therapy for pain that we are experiencing is very costly financially, but even more costly to the patients themselves in the loss of their quality of life. So there really is a desperate need for these alternatives for pain management. 1 in 5, how many of you in this room, raise your hand if you would say you suffer from chronic pain or you know someone who suffers from chronic pain. So it affects us all, whether we are the ones suffering or not. Maybe a loved one is suffering and they can't get adequate pain control. I think this paper was already covered earlier, so I'm not going to spend a lot of time on this slide, but this was just an association made when they looked at overdose deaths in states that had medical cannabis, that there was a decrease in those deaths that occurred after the passage of medical marijuana laws by almost 25%. In 2016, and there's been several surveys, so if you know of another one that I left out, it wasn't intentional, I just couldn't cover it all, but a lot of surveys of patients using cannabis as a medicine have shown that they use for pain and that they find that it gives them pain control and often the ability also to cut back or eliminate opiate medicines. So, and not only that, but they report, as we heard earlier, that they have less side effect associated with cannabis use, and they report improved quality of life as a result of using cannabis. So I've had an ongoing cannabis use survey in collaboration with Bastyr University, and this is some data taken from subjects who identified as medical users of cannabis only. And they reported 61% used cannabis for their pain. And then if you look at the number 2 and 3 highest indications for use, we have anxiety and depression. And this is notable because pain patients often have anxiety and depression. We did another analysis of this data where we had asked questions on whether they substitute cannabis for prescription medications. This was 2,864 people. 46% responded that yes, they substitute cannabis for other medications, and the top medications being narcotics or opiates, and then next, not surprisingly, anxiolytics and antidepressants. Medical users were 4.6 times more likely than non-medical users to substitute cannabis for pain medications. Females were 6 times more likely to be substitutors for pain medications. And this is not surprising because if you go to the scientific literature, there's quite a lot of data on how cannabis acts as an analgesia. We know the molecular details involved in that, how the endocannabinoid system is involved. And so when co-administered, what's really interesting is that you can get a better efficacy of pain relief by administering cannabinoids and opioids together than by administering either of them separately and at a lower dose. And so this is really important when we start thinking about the side effects of opiates and the need to continue dose escalating. That if you can even reduce the amount of opiate, all patients may not be able to totally get off of opiates, but if by adding cannabis you can reduce the amount of opiate they're taking, you're going to improve their quality of life and probably have pain relief. This was actually a meta-analysis that was done looking at many animal studies, and if you've never seen how a meta-analysis is reported, the difference at 0 means that there's really no indication from the analysis of many, many studies showing an effect. But the large diamond on the left-hand side, it was showing this just in these few animal studies, and they also looked at clinical studies, that there seemed to be reduced opiate requirement when adding cannabinoids. And this was specifically THC. So there's a lot of information, like I said, on the endocannabinoid system, its role in pain. We know this is because the CB1 receptor is in both neurons and in non-neural cells. We know that in pain, that the cannabinoid receptor is transported from the dorsal root ganglia out to the peripheral nerve terminals. CB2 receptor is also expressed, but primarily in immune cells. There's been some reports of it also in the dorsal root ganglia. These cells are also in the keratinocytes and in tissues at the surface of the skin with our sensory input. And that expression of these two protein receptors is enhanced by injury and inflammation. So we'll see often an upregulation of these receptors. So he mentioned in my introduction that I had done some work looking at the effects of cannabis in multiple sclerosis. So that was the topic of my postdoctoral fellowship. And one of the first experiments that we did, we were interested, because of MS, the primary strategy is to keep immune cells out of the brain. And we knew that the cannabinoid receptor has an involvement in migration of immune cells. We wanted to know if people using cannabis had any different migratory capacity. So we looked specifically here at macrophages. They were isolated out of the blood. And this just showed that these were all healthy subjects at this point, that if they were cannabis users, that their immune cells didn't move around quite as much as people who were not cannabis users. And so we were asking their immune cells to migrate in a chamber towards something called a chemoattractant. The other thing that we showed was a differential expression of cannabinoid receptors, and this was measured on immune cells. So interestingly, there is thought that immune cells can be sort of a mirror of what's going on in the brain. And this isn't such a wild idea, although some people think it is a wild idea, because we know that the central nervous system and the immune system have a lot of talk going on, and we're going to get into that a bit more. The other thing that we measured in our actual study on the multiple sclerosis patients was a global decrease in cytokine expression. And so these are inflammatory compounds that are telling the rest of the body how to react to what's going on. And so this is a problem in multiple sclerosis, that there's a lot of inflammation. And so we showed that whether they were healthy subjects or patients with MS, if they were using cannabis at all, that they had greatly reduced amounts of these cytokine markers. So just to summarize this section, chronic pain's a problem. We know the endocannabinoid system is involved in pain processing. People are using cannabis already to treat their pain on their own. THC seems to have an opioid sparing effect, meaning that if you administer THC with opioids, you can reduce the amount of opiate and get the same pain relief, and that cannabinoids have effects on immune function as well. So now I wanted to just take a minute to devote this next section to talking about our endogenous opiate system, because it's sort of like fallen into disfavor, I think, because of the negative commentary on opiates. But this is a critical system in our body also, that there's a plant medicine speaking directly to this system. So it's the best studied system in pain relief. We know that there are 3 classes of endogenous opioids that our body makes, just like we make endogenous cannabinoids. There's 3 classes of receptors, opiate receptors. And interestingly, just like the endocannabinoid system, immune cells have these opiate receptors, and immune cells can make these opiates as well. And the worst thing of all is that by administering opiates, we're inhibiting the immune response, probably directly through this opioid system. However, opioids are the drug of choice for treating severe pain. They used to be sort of reserved only for severe cancer pain, but they started becoming used more widely just for all chronic pain, despite the fact that people develop tolerance and dependence, and in the end, something called hyperalgesia, which is heightened pain. The pharmacologic effects of opiates administered by prescription are primarily through the mu opioid receptor, and there's good evidence that Just by administering morphine, for instance, that we are inducing inflammation in the body. So we're going to talk more about how on earth is this happening. These are the prescription opioids most commonly used in Australia in 2011. You can see that there's some short-acting ones listed at the top. There are longer-acting opioids listed at the bottom. So this is an interesting paper that I came across, and I really wanted to know more, and I don't expect you to read all of this, but I could not access this paper, although that it was published over a year ago. So often when when a paper is first published, there will be what's called an embargo by the journal, where they have a copyright on it, and it can't be widely accessed for a period of time, often a year. So I went to the journal to get this paper. All of the other papers in that issue were available by PDF, and this paper was not available. And it just said there is currently an embargo on this paper. And I thought that was interesting. And if you look at the very last sentence that I highlighted in red, it says that the increased use of opioids was largely driven by the subsidy of longer-acting formulations and opioids for the treatment of non-cancer pain. So they were specifically trying to determine how much opioid was being used in Australia, and they had a good means of doing that, which was the National Drug Subsidy Program, who had a record of all of this. So not only in the US, but in Australia, there's a problem with a lot of opiates being used. And so that brings us to the topic of opioid-induced hyperalgesia. Was anybody up late last night watching the late, I don't know what it's called, the late something on ABC? Did anybody see it other than Jonathan? You saw it? Yeah, so I succumbed to my travel fatigue and was not up that late, but apparently one of the topics last night was opioid-induced hyperalgesia, so you might be able to catch that in a rerun. So the definition of what I'll refer to as OIH from here on out is alterations in pain perception caused by exposure to opioids. The condition is characterized by a paradoxical response whereby the patient receiving opioids for treatment of pain could actually become more sensitive to certain painful stimuli. And that's specifically called allodynia. So hyperalgesia, meaning more pain, and allodynia, meaning something that really shouldn't be pain, like cold, feeling very painful to the patient. So there's clinical signs of this. Tolerance, which means they may be on really high doses of opiates and yet they still have what's called breakthrough pain. Dependence, where they can't come off of the opiate. The mechanical allodynia or thermal hyperalgesia that I was just talking about. And then there's some behavioral effects as well. One is called catastrophizing. So these patients, they come into my office, they sit down, and for the first 30 minutes, they literally have to unload their entire experience with pain, which may have gone on for 20 years. They want to go through every single operation that they've had, every procedure, every doctor that they perceived treated them unfavorably or without respect. And then their mind will just keep spinning off on bad things and how nothing good can ever happen to them. And so they're also usually suffering from anxiety and depression as well. So here's an example. This was a 63-year-old female. She had had a recent surgery for repair of her rotator cuff and was suffering from pain from that. But even prior to that, this woman had been fused literally from the top of her cervical spine all the way down to her sacrum. So anybody in this room have a fusion? No, anybody have a fusion? Nobody? Oh, I can't even imagine the thought of it, because they literally go in and put metal plates in and fuse your vertebra together with long screws. And I knew somebody in medical school that had, I think, 2 levels of fusion, and she suffered from excruciating pain all the time. So it doesn't really seem to be an answer for anything. And this woman, I mean, she has zero quality of life. She could barely walk. She used a walker. She suffered from extreme anxiety, constant insomnia, of course, constipation. And if you look at her drug list, there's different scales called the morphine equivalent daily dose, and the one that we use to calculate her morphine equivalent daily dose is 1,088. She had drugs on hand in case of an overdose, and so she had been recommended to use cannabis. And I'm going to talk more about her later, but I just wanted to bring it home that who these patients are, and they're probably someone that you know. So how does this opioid-induced hyperalgesia work? We actually know a lot about it. One way is by decreasing dopamine transmission in a certain pathway in the brain, and a lot of you probably know that dopamine is one of our primary pleasure hormones or neurotransmitters. If you chronically agonize that mu-opioid receptor, so for instance, morphine is an agonist at the mu-opioid receptor, you'll see the same loss of dopaminergic function that is seen in inflammatory pain. And that it also suppresses immune function. It impairs macrophage and T cell function. This whole machinery, as I said, is in the immune cells. And by administering morphine, you inhibit the production of the natural endorphins or the natural opiates, which are actually there for good cause, for pain relief and for modulating the immune system. And then there was an interesting paper that came out, and just for your information, these small numbers, the 8 and the 9 and the 10, these are all references, and they'll be at the end of the talk. A paper in the Proceedings of the National Academy of Sciences came out showing this mechanism of how morphine was actually prolonging and causing ongoing neuropathic pain by amplifying the signaling of something called NALP3, which is an inflammasome, which activates inflammation. And then I found this paper just today, something else associated with this NALP3 signaling. This is called toll-like receptors. And toll-like receptors are typically activated by infectious agents or toxins produced by bacteria, but things in our own body can also activate these toll-like receptors, such as mechanical damage. And so it activates the immune system. We need to heal, and so the immune system's trying to go to work. And so these toll-like receptors are in the central nervous system. They're on immune cells. The TLR4 has been shown to be a pain initiator, and that using analgesics that activate both the mu-opioid receptor and the toll-like receptor 4 may worsen the entire pain scenario. And then I put this example where they've drawn out all the different mechanisms that they could find in the literature, so we know precisely how opioids are contributing to pain, and that's the point here. So we know that there's an endogenous opiate system. It's present in our neurons and on our immune cells, just like the endogenous cannabinoid system. And that administration of opiates has been shown to cause paradoxical pain, and we even know exactly how this is going on. So now I want to talk about something called the neural immune reflex. So if you just look at basic inflammation, there's all these different inputs going into it, and so what should happen is that immune activation should resolve on its own, and that's a natural process, and this is something that we've learned the endocannabinoid system to be involved in the homeostasis of the immune system. But if you don't get resolution of inflammation, you have chronic inflammation, which is also associated with chronic pain. So how this works is at the bottom of this diagram, you can see that there's pathogen or there's tissue damage, there's pain. When that occurs, there's pro-inflammatory cytokines. This is signaling in the brain, contributing to the pain experience. And so then there should be this negative feedback loop coming back to turn the immune system off and resolve pain. And so this is how immune cells and neurons are communicating through these same signaling things we've been talking about, the cytokines, the endogenous opiates, and the endogenous cannabinoids. And so this is called the neural circuit. Our brain is involved in the regulation of our immunity. And then this is just kind of going down to the next level by which this negative feedback loop occurs. We have a really big nerve coming out of the brainstem. It's called the wanderer, the vagus nerve. It's communicating back down to all of our internal organs from the brain, directly from a location called the locus ceruleus through a neurotransmitter called norepinephrine. And that norepinephrine comes signaling down the vagus nerve. It talks to T cells. The T cells are then producing acetylcholine, and the acetylcholine is turning off the innate immune system. It's calling the immune cells home. And so this is what should be happening in a normal reflex arc of this neural immune system. What we also know is that there is significant crosstalk between the cannabinoid and opiate systems. That we already talked about how they both have some control on sedation, hypnosis, regulation of temperature, analgesia, intestinal motility, and pain. So we know that they are involved in common things happening in the body. It's been shown that cannabinoids can enhance opiate potential and the opposite. If you put them together, there's greater than additive effects. These two systems are co-localized in the brain and on immune cells, and there's even been shown that at the individual receptors, for instance, that beta endorphin, for instance, can bind cannabinoid receptor, or some cannabinoids can bind the opioid receptor. And we even know that both receptors can even join together in what's called heterodimerization, and that leads to different types of signaling. So it's interesting that the two systems are really engaged together in crosstalk in the body, and they're doing similar things. So with this in mind, we have submitted a proposal where we want to evaluate this crosstalk in human subjects. And so here's the working diagram of the pain being initiated, that we're going to enroll patients who are having chronic pain or neuropathic pain, and we're going to measure certain elements like the cytokines. We'll measure the endocannabinoid system. We'll measure the opiate system. And then we will administer cannabis of 2 varietals either with or without cannabidiol, and see if we can measure changes in how these systems are talking together. So we know that these systems talk together, that opioid-induced hyperalgesia has an inflammatory component. They talk together, and the cannabinoids, we think, may be involved in helping restore this normal neuroimmune reflex and maybe reverse some of the damage that's being done by chronic opiate administration. So let's talk just a bit about clinical studies of inhaled cannabis. So the CMCR is the Cannabis Medical Research Center in California at the UCSD, and they're a center within the university that's got some money from the state of California when the medical law was first passed so they could do some investigations. So there's been a lot of study specifically on pain, and the results have been convergent, meaning they are all arriving at the same conclusion, that there is a significant decrease in pain after cannabis administration. Again, this is inhaled cannabis using a flower vaporizer. And if you look at clinical studies, something always good to know as a clinician is the number needed to treat. So that is, how many people would I need to treat with this drug? How many out of what number are going to have an effect? So if you look at tricyclic antidepressants, the number is you're going to need to treat 2.2 people. So, 50% are going to have a good effect. And then if you look at cannabis, it's not far behind there and is better than some of the other drugs that are often being used as add-on medications for pain. So cannabis is a rational choice as an add-on for pain. This was a study by my collaborator, Dr. Mark Wallace, who's the head of the pain department and anesthesia at UCSD. And they compared 3 doses of cannabis, and this was cannabis provided by the University of Mississippi through the NIDA program. And so it's really low potency cannabis that's available. You'll probably hear more about that from Sue. Are you going to talk about that, Sue? But regardless of it being low potency and not really matching what people are using in the real world, they had efficacy even at a pretty low dose, which was a 4% THC. And there was even indication that as they went up in THC dose, there was not as good pain relief as at the lower dose. So this kind of, flies in the face of a lot of the advice that goes out to patients when they visit a dispensary, because the varietals available are 20% THC and up typically. And patients are encouraged to use that really high dose, but we've always known that there's been sort of a sweet spot for pain, and that you can go too high and THC may actually exacerbate pain. So this was just corroborated by this study that Mark Wallace did for painful diabetic neuropathy. Here's a list of all the studies of inhaled cannabis for pain that have been done in the US. But again, going back to this topic of what was being used in these studies and what's being supplied by NIDA doesn't really match what's being used by the medical community and what's available to them in dispensary systems. So this was data that was compiled primarily through a lab that has facilities in different states. And you can go to the NIDA website and get this potency data on all the varietals that the University of Mississippi has available. And so you can just see by comparison that the THC content and the CBD content of what NIDA has available doesn't really match what patients are probably actually using most of the time. So they were just saying, this may really, question the external validity of all of the sanctioned research that's been done in the cannabis that's been used. So let's talk a bit more about cannabis use in clinical practice. I really like using inhalation and using the whole flower and a vaporizer for this inhalation, because for pain patients, they want pain relief and they want it now. And if you look at pharmacokinetic data on inhaled cannabis, for many, many patients, it's all the same. It goes into the lungs, it goes into the bloodstream, and it's really rapid. Whereas if you give it orally, it's really a lot of interperson variability. And it's been suggested that patients can self-titrate and be successful at it. I mean, we allow people to do that with opium pumps in the hospital, and we don't often send them home with that. There are people with pain pumps, but for vaporization and inhalation, that patients can usually titrate to find their own best dose with the least amount of side effect. So I just want to take a minute to talk about cannabidiol specifically, because I think there is a real misconception about cannabidiol, especially, I don't know about here, but definitely in America, the marketplace, I think, has given the public a perception that CBD-only cannabis or CBD products made from hemp and however it's all been processed is just still cannabis, but without the high. And so I have to say, by the time a lot of patients come to my office, they have already tried CBD and they have gotten no pain relief. And there are 0 human studies at this point showing that CBD is an analgesic. And so where's this coming from? I'm not really sure, but people are often very disappointed to hear this because they thought they could have cannabis and not be high and still have pain relief. On the other hand, CBD has been shown to have anxiolytic effects, have some anti-inflammatory effects. It's been shown to modulate the endocannabinoid system in a disputed fashion by increasing the levels of anandamide. There's a paper showing that it actually decreased the activation of that inflammasome, the NALP3 that I talked about morphine exacerbating. And it also may modulate mechanisms in the brain having to do with dopamine and the experience of addiction. So there's a lot of good reasons to have cannabidiol on board for pain, but in my experience, it is not primarily a pain reliever, at least not for the complex types of pain that I see in practice. So what do they use? So I've worked out a protocol, and I instruct the patients. Basically, I try to tell them how to shop for cannabis because they're going to go out and purchase product. So there's a varietal called ACDC. It originated in California. It was the first one brought up to Washington that the pediatric patients with epilepsy used. It's quite predictable for its high ratio of CBD to THC. And then I'll have them purchase also a THC varietal, and they're going to mix these and titrate the THC in for themselves. And so often I'll have them start with just the ACDC varietal by grinding it, putting it into the vaporizer. And these are people that, typically come in, and the first thing they say to me is, I do not want to be high, and I am not going to smoke pot. And, so I have to appreciate how they're willing to do it and what they're willing to do, but I do try to persuade them that this is not smoking, that this is the best way to get it into their system, and it's going to be really rapid. So I talk about this mixing, like making enchilada sauce. I don't know how much enchilada sauce you guys make in Australia, but I love to make enchilada sauce, and I love cumin. And so I tell them the CBD is like the cumin, that they can put in like 2 tablespoons of cumin, but when they get to the red pepper, they want to start with just a pinch. And so to think of THC as the red pepper, because they're just looking for the therapeutic efficacy, but still wanting to be as functional as they can be. And they're tired of being groggy from the gabapentin and the tramadol and the oxycodone. They're really wanting something different. And so for the THC varietal, the one that I've stuck with is it's the best seller in the entire West Coast and in Colorado, probably for 2 reasons. One, because it's a very good producer, and I think that people really like it because of its terpene profile. So if you look at the bottom 2 monoterpenes are beta-myrcene and alpha-pinene, and if you look at a lot of analyses of plants, you don't see this kind of 1-to-1 ratio very often. But I think that it's specifically the presence of this pinene and in such high concentration. And the reason for that is that there's evidence that it inhibits the breakdown of acetylcholine, which is a neurotransmitter that improves cognitive function. And we just talked about acetylcholine being involved in this neural immune reflex. So this is the one that I have them start with, and I tell them it's just their initiatory package, and after that they're welcome to go try other varietals. If this doesn't work, we talk about other terpenes to look for, and I really try to educate them about how to shop. So again, here's this data from Dr. Wallace's study showing 3 different potencies of cannabis, the inhalation, and you can see how uniform this is time versus measuring THC in the serum. And so across all patients, it's really predictable that it goes in really quick. You can measure it quickly. It rises really fast. On the other hand, if you administer it orally, these are just 3 different patients, and on the x-axis now is hours instead of minutes. And so you can see that one patient had a peak concentration at 1 hour, one of them was at 2 hours, and one of them was all the way out at 4 hours. So it's not as predictable as inhalation, but I'll still have patients use oral administration. Here's an example of like a little chew they can get. It's really hard to find low THC, but I start them on literally 1 to 2 milligrams, and this little chew that they can get if they cut it into fourths is 1.25 milligrams per quarter of the chew. And so again, I have them just slowly titrate upward. And so they can inhale, follow it with something oral, and get much longer pain relief. So let's follow up with that patient number 1. At 2 months, if you remember, her morphine equivalent daily dose was 1,000. By adding on cannabis, she had now reduced her morphine equivalent daily dose by 2/3. And she was able to go back to PT. She got down to a certain point in her opiate taper, and she hasn't been able to taper further. She's still having some anxiety, but cannabis has really helped her sleep. And even though her pain scores aren't necessarily significantly improved, we also look at what we call relief scores, which really look more at the quality of life of the patient. So they may still be in pain, but their relief is higher. And this is what I often tell patients is, you may still have pain, but you're gonna have an altered perception of your pain. And you may just be able for the first time to realize that the sky is blue because your mind isn't totally focused on your pain all the time. So then I want to talk about this other patient because this is a really difficult patient who constantly catastrophized. He had a sarcoma, he developed a sarcoma. He subsequently got a MRSA infection. He had radiation, which led to some severe radiation cystitis. And this man, I went and visited him in his home. He had literally almost not left his bedroom for 9 years. Very successful real estate developer in the San Diego area. I mean, he literally cries every time I talk to him on the phone. So anyway, he had all these problems. He had burning tongue from the radiation, constant abdominal pain. Anyway, he was on a bunch of drugs already, and they've tried every procedure they can think of for this man. And so he had tried a CBD product. That's what he had in his home when I saw him. He had no pain relief. So I got him started inhaling cannabis, and ends up the dispensary. They had to babysit this guy all the time. He was very wealthy. I think he probably tried every product that they had in their dispensary. And he eventually, there's a guy in the San Diego area who is a pharmacist, and he's developed a lozenge that you kind of just stick up, between your cheek and your gum and let it dissolve. And that was like one of the last things he tried, and he finally got relief from this. So he is one person that actually has required a much higher dose than most of the other patients. So we know that inhaled cannabis has efficacy for neuropathic pain. There have been no formal trials for CBD for pain, and if I'm wrong on that and anybody knows, please let me know because I haven't seen them. By inhaling the whole plant medicine, they're getting the whole package. They get rapid effects. They're pretty reproducible across patients. But patients can be highly variable. Some will respond to really low dose. I would say the majority respond to quite low dose for their pain, while others may not. So when you're approaching the pain patient, I'm a naturopathic doctor, so I don't treat them in a vacuum at all. I'm assessing the whole person. We're talking about their diet. We're talking about specific nutrients. Exercise is really a number one thing because by exercising, you're stimulating your natural cannabinoid system, you're stimulating your natural opiate system. Often my patients are getting really good integrative care through the UCSD system. Not everyone can afford that or have access to that. They're getting mindfulness-based meditation, they're getting acupuncture, they may be getting massage, physical therapy, osteopathic manipulation, and it's this whole package I think that really is required for treating difficult neuropathic and chronic pain. And then don't forget about all the other effects that morphine can have on their functioning, impairment of osteoblasts so they can develop osteopenia or osteoporosis with long-term opiate use, decreased sexual function, sexual steroid production is going to be down in these patients, acetylcholine, signaling interruption, really bad cognitive function often, and of course, bowel problems associated with the opiates. So how should they do this? How should they taper their opiates? Not in a vacuum. Again, it should be a coordination of their caregivers, specifically whoever is prescribing their pain medications, and sometimes they may even have multiple prescribers of their pain medications. Sometimes they're going to a specific pain doctor, and that's all these pain doctors do is prescribe opiates. They may be seen by the pain center at UCSD. They may have their primary care provider prescribing opiates. And so it's unethical for me to remove a drug if I didn't prescribe it. So I really ask them to go back and engage with their doctors and say, this is what I want to do. I need you to help me. And more other caregivers in California are getting interested, like the cardiologists. They want to know now if their patient's going onto cannabis. And so they may need that to monitor any cardiovascular medications. Typically, we try for a taper of 10% a week, but this is really in an ideal world. Some patients can do it, others absolutely cannot. Ask them about their alcohol use, because I think often they're using alcohol with their opiates. This may be interrupting their sleep, and it may also be exacerbating their pain. And I just tell them, substitute the cannabis for your alcohol. It's safer for you and non-toxic. So other supportive therapies that I use are a dose escalation of CBD. And now I'm talking about pretty high doses. We think that the efficacy of CBD for many things is probably much higher than what's being sold on the marketplace. For instance, many of the products I see are 2 to 5 milligrams of CBD. And for what CBD does, it's probably not an efficacious dose. Curcumin is a compound from turmeric. It was shown to attenuate morphine withdrawal in rats. It's also an anti-inflammatory, so I put all my patients on curcumin. And then there's some other add-ons I'll use, like theanine, which is a compound from green tea that has a calming effect, lithium orotate, which is a very different form of lithium than what's given for bipolar disorder, omega-3 fatty acids, and then I really stay on their case about exercising and also getting some other type of body work. So again, consider the patient preference. How are they going to be most likely to use it? And if they're just not going to inhale it, they'll often start with something oral, but they'll say, well, if this doesn't work, then maybe I'll consider inhaling. The cannabinoids don't potentiate the opiates or raise the level of the opiates in the bloodstream, and so a lot of patients are worried about, can I actually use cannabis? I know there's problems with drug mixing. Can I mix cannabis with my opiates and I'm not going to die? And then they want to know how often can they use, and when they're trying to taper opiates, I tell them whenever you feel pain, because the goal is you're trying to get off of your opiates. And so use it. So for some patients, if they tell me that they wake up in their worst pain, I say wake up and inhale. Start your day off with a better start than having to take an opiate and wait a few hours. Some people set their alarms for 4 o'clock to take their opiates so they can go back to sleep and wake up and have less pain. And so then again, like I said, to inhale first, follow it with something oral for longer relief. But generally, the relief from inhalation seems to last about 2 to 4 hours, which is less than the oral administration because it's really bypassing the liver. Some patients can withdraw totally. Other patients can just taper down to a much safer level and have better pain relief by combining the two. So what's the significance of this pain research? We want to help to make sure that the medical community doesn't repeat the same mistakes made with opiates pharmacy, which would be unchecked prescribing with adverse events of epic proportions. We don't foresee that happening with cannabis, but I think that, we still need to do the research. And we want to support federal guidelines that are emphasizing opiate tapering and provide a rational therapeutic alternative. We want to address gaps in the medical education by providing data such as these, and to give physicians an evidence base for the practice of using cannabis in clinical practice. And we also want to allow for the physician participation in the treatment plan of using cannabis. Here's the full list of references. I think these will all be published for you guys post-conference. And thank you so much for your attention. And this is just acknowledgement of my collaborators.